Hello everyone and welcome to our 2018 Billing and Coding webinar for Body Gears Physical Therapy. My name is Robbie Leonard. I am a PT and I was asked by Body Gears to work with your team on your billing practices and your business side of things to help you continue to grow and develop as a company. This information is for your staff only, and please do not share a copy of this information without permission. We're going to start off and talk a little bit about ICD-10 codes, and then we will move into CPT coding and spend the bulk of our time there. The ICD-10 codes are the diagnosis codes that you use to justify treating your patient. You have two types of diagnosis that you use, the patient's medical diagnosis and the patient's therapy diagnosis. And the question you need to ask yourself is, does the diagnosis paint a picture of medical necessity and capture the complexity of care? So when you're choosing therapy diagnoses, for example, if a patient has a pain issue, obviously you typically choose the pain diagnosis, but that alone may not paint the picture of complexity of the patient. Do they also have weakness and stiffness and difficulty walking and those sorts of things? So you want to make sure that you're choosing the diagnosis that will support the medical necessity for treating the patient for as long as you intend to treat the patient. We're going to spend the bulk of today's webinar on CPT codes. This is the CPT code book is published by the American Medical Association every year. There's a code for every procedure, and the CPT rules govern all the coding. So we want to make sure that you understand the CPT rules and where those rules might differ from a more restrictive payer such as Medicare. Not all payers allow all CPT codes, and those are specific to states and for specific to contracts. So we'll be helping you with some more detail on that. All the payers have to follow CPT rule because of HIPAA law, but not all payers follow the Medicare rules. So we want to make sure you understand the difference between the CPT rule and the Medicare rule. And then contracts and medical policies dictate those rules. And so I've been spending a good amount of time reading through all of your contracts, looking at your payer policies for each of your states, and looking at what are the rules for the payers that Body Gears contracts with, so that we can make sure that you understand the rules based on the payer's information. We always say therapists should bill according to the purpose of your care. What is your goal for that procedure that you're doing? And making sure that you're providing care following the specific rule of the payer. The CPT codes are owned by the American Medical Association and trademarked and copyrighted, so I want to make sure that you understand that I'm only using these for educational purposes. This is summary information, and in order to get detailed information, you would need to look in the CPT book. So there is two types of codes that we use in therapy, timed and untimed. The timed code usage is based on the CPT rule for one-on-one intervention measured in units. And back in 2005, the CPT committee clarified that in order to bill a 15-minute unit or a timed unit, you need to do at least reach the midpoint of that time. And that's where we got the 8 minutes. So technically the midpoint's 7.5, but I guess they rounded up to 8. And that's called using a substantial portion of the code. Untimed codes are codes that we bill, and we get to bill one of these per treatment session based on the definition of the code, regardless of the amount of time it takes. So the untimed codes that you typically bill are evaluation and reevaluation codes. Untimed codes also include some modalities that you rarely use. I have taken a look at all your payer data, all your code data. You're not big modality billers, which is great, but we'll take a look at a few of those. So let's spend a few minutes on evaluation. We won't spend a tremendous amount of time, but I just want to remind you what these codes look like. So we have 3 evaluation codes as of January 1st, 2017, low, moderate, high complexity. Those are untimed. They have to be done by a PT. You always evaluate the patient when you start treating the patient for a new condition. If the patient had been seen in a different outpatient practice across town, ATI or someone else, and now they are coming to you, you are always allowed to evaluate the patient first before you treat them, and you're expected to. The evaluation code includes taking the patient's history, reviewing systems, the tests and measures that you're going to do, providing a standard outcome assessment, and determining the patient's current functional status. Typically, when we evaluate the patient, then we would also treat the patient on the same day and bill treatment codes. Now, I know that you do have a limitation in your Illinois law that if a patient comes to you without a physician's referral prescription, that you're only allowed to evaluate, and then you need that physician to sign off on that patient's diagnosis plan of care. So our 3 codes are 161, 162, 163 for evals, and then we have a re-eval code, which is 164. When the codes came out back in January and I started educating therapists on this, the expected distribution when the codes were published was that we would have about 25% low complexity evals, 50% moderate complexity, and 25% high complexity. When I took a look at your 2017 data, you had 64% low complexity eval codes billed, 32% moderate complexity, and 3.5% high complexity. So, and your data is not much different than other outpatient therapy clinics that I work with. I've worked with about 80 different outpatient clinics across the country over the last years, and when I look at aggregate data, your numbers are very similar to what I'm seeing elsewhere. And it's because we're not getting paid differently. So most therapists have defaulted to the low complexity eval because it's obviously way easier to document a low complexity eval. And because you're not getting paid different, maybe there's no thought that I need to do something different in this space. But I will tell you that it is important to use the correct complexity eval for a couple of reasons. 1, for data purposes, and 2, to support the medical necessity of the complexity of the patient that you're treating. So if we look at the low complexity eval, there's 4 categories in each one of these evals. There's the history, the examination, the presentation, the clinical decision-making. In the history side, it's personal factors and comorbidities. In the examination with the low complexity, it's addressing 1 to 2 elements in your exam. The presentation is stable and are complicated, and the clinical decision-making is low complexity. I think that these 2 categories are easy to meet. Personal factors and comorbidities. Just as a reminder, personal factors are things like the patient's bedroom is up the stairs, they have to drive a long distance to work, they sit at a computer all day, they work as a construction worker, something like that. Comorbidities are your traditional medical comorbidities, such as diabetes, obesity, etc. 1 to 2 elements, we always, when we do our examinations, our evaluations, we're always doing more than 1 to 2 elements. Those are things like strength, endurance, range of motion, joint mobility, all the things that you are testing and checking during your examination. And then I think this is the category that hangs people up, is stable and or uncomplicated versus evolving and changing and unstable, unpredictable. This is therapy presentation, not medical presentation. So this is not stable and or uncomplicated from a medical perspective. It's stable and or uncomplicated from a therapy perspective. So this low complexity eval patient is going to be the patient that's not going to be with you for a long period of time. 3 or 4 visits, they're going to be easy to treat. They're going to have low complexity. It's a straightforward condition, straightforward issues, and you treat them and move on. The moderate complexity, 1 to 2 personal factors or comorbidities, 3 or more elements that we evaluate, evolving clinical presentation with changing characteristics. So these are the patients where their clinical symptoms, their issues are evolving, they're changing, their pain may be better or worse depending on what they're doing. They have issues that aren't always the same every time you see them or on every day. So that's what moderate complexity looks like. And then high complexity, 3 or 4 personal factors or comorbidities, 4 or more elements in your exam, and unstable and unpredictable. I would say some of your spine patients, for example, will fall into this category of unstable and unpredictable. You guys see some patients have a multitude of issues going on, different diagnoses, multiple problems. So some of those patients may fit into this high complexity eval. And so I would just say that, take a look at how you're building your eval, make sure that you're using the correct code that really paints that picture of complexity of the patients that you have. I've seen some of the patients that you're treating, I've looked at some of your documentation, and I will say that I think you're not seeing 60-something% low complexity patients in your practice. Obviously, you're still not getting paid differently for the eval codes this year, but future year payments are going to be dependent upon the data that's been captured for the last 2 years. So you also aren't billing too many re-eval codes, and payment is good for that code if a payer allows it. So we'll talk a little bit further about the re-eval code. If you're not going to get paid different, why does it matter? Well, Medicare and your other payers are tracking utilization in order to set future pricing. So we want the body gears data to be accurate so that when the pricing does come along, that your information is correct. If they begin to audit these new codes and you're not using the proper code, that could result in future denials. And remember that correct code is going to help reflect medical necessity and the length of stay of the patient. The re-eval code by definition includes reviewing the history, doing a standardized test and measure, and revising the plan of care based on the findings of that reevaluation. Medicare specifically does cover this code and covers it fairly well and says that you can bill this code and just look at the red print if there is a significant improvement, decline, or change in the patient's condition or functional status that was not anticipated in the plan of care. So if I have a patient that I plan to see twice a week for 4 weeks, and I begin treating the patient, I get to the 4th week mark, the patient has not completed their plan of care. They missed a week of therapy because they had the flu. They're not making progress as expected. Then that patient would meet that definition because their functional status is different than I anticipated in my original plan of care. I need to reevaluate, change the goals, reestablish my plan of care. I would build that reeval on that date of service and then continue to treat the patient. And we gotta have a little humor when we talk about billing and coding because it's a pretty dry subject, especially when you're listening to it on a webinar. All right, other untimed codes that you could possibly bill. The supervised modalities, this is a list. You don't use any or very many of any of these, but I do see a few unattended eSTEM codes being billed. So what that means is that you can put the electrodes on that, set them up, have them set up for eSTEM, you walk away, and you bill 1 unit of eSTEM unattended for that treatment session, regardless of how much time the patient spends getting stimulated. And you can walk away and treat someone else when you're doing supervised modalities. Group therapy, again, is not a code that you bill if at all, but I want to make sure that you understand what it means because this is a really common question and a commonly misunderstood code. Group therapy is not supervised exercise. It's a constant attendance of the practitioner, but not one-on-one. So for example, let's say I have 2 patients in the gym at the same time. If I am standing between the 2 of them, supervising both people, but not one-on-one with either, that would be group therapy. But I would have to be there with both of the patients and supervising both of them simultaneously. They can be doing the same thing or different things, it doesn't matter. but I'm not one-on-one with the patient. But the reverse of that scenario is, let's say I have both patients in the gym at the same time, but I spend 10 minutes with one of them and then 10 minutes with the other one. So I spend 10 minutes one-on-one with each one of them. Then I could build each one of them individual therapy codes for the 10 minutes that I spend with each one, and that would not be group therapy. So if you do build group, there needs to be clear documentation of the skill that's required. It's by definition 2 or more individuals and no more than 4 for Medicare. Medicare is one of the few payers that will actually pay for group therapy. Most of your commercial payers do not pay for this code. Some of you do this. Canalith repositioning 95992 is an untimed code, and it is a designed code for a visit where you're doing a Canalith repositioning procedure, such as an Epley or Samant. You can only bill 1 unit per day because it's untimed. Obviously, the patient should have an appropriate diagnosis code, so something like BPPV or vertigo, and you bill this code on a day when you need to do the Canalith repositioning procedure. Not all payers allow this code. We'll get you some more information on that, but Medicare does cover it and pays well for it. So if you have a Medicare patient with BPPV that you're doing an Epley with, then it would be appropriate to bill the 95992. All right, we're going to spend the bulk of our time on timed codes that you frequently bill. And so I want to start off in the CPT book. This is a definition that sits on top of all the timed codes and applies to all the timed codes. And so the definition straight out of the book is the qualified health professional, such as the PT, OT, speech therapist, is in direct contact with one patient while using techniques specific to the definition of the code. All right, so that is the overarching definition. And I always want you to have a reference for anything that I'm telling you. It's not Robbie said. It's based on the CPT book. It's based on Medicare rule. It's based on your payer contracts, etc. Not my opinion. So back in 2005, in the CPT assistant book, they further defined what 15 minutes was. And so what they said was that in order to bill a 15-minute unit, the therapist needed to do a substantial portion of 15 minutes in order to bill the code. And then they further defined that at a later time frame as at least half the code. And so in the definition of the code, if you look in the CPT book, it says the work of the therapist consists of direct contact time spent with the patient and caregiver when appropriate deliver skilled services. Then they split this out into 2 sections. So if, for the purposes of determining the total time of services under certain payer policies, incremental intervals of treatment during the same encounter should be accumulated, and the total time of the service should support the number of units billed. That, in orange-ish color, is the Medicare rule. Okay, so for purposes of making sure we are speaking clearly, we're going to call the Medicare rule the total time rule. So if Medicare says you have to take the total amount of time you spend with the patient and add all that up, and you can't bill any more units than the total time allows. However, this is the second part of that definition. If the provider is being paid incrementally, then a unit of time is reached when the midpoint is passed. And so that's the commercial payer rule. So basically, if you do something and you spend at least half the code, then you can bill the code if you're being paid incrementally. So for example, Blue Cross Blue Shield in all 3 of the states that you're in pays you incrementally. And so if you get to the halfway point, you can bill a unit of service. So what does that mean? So halfway has been defined as 8 minutes. Technically it's 7.5, but we'll go with 8 because that's how they defined it. 8 minutes through 22 is 1 unit of something. In order to get to the second unit of the same thing, you have to get to 23 minutes. So for example, in order to bill 1 unit of Therex, I'd have to do it more than 8 minutes. In order to bill 2 minutes of Therax, I'd have to do more than 23. In order to bill 3 units of Therax, I'd have to do more than 38. Now, Medicare takes this a step further and does the total treatment time. So basically, Medicare says, we want you to take the total amount of one-on-one time you spend with the patient, and that's going to constrain the number of time units you can bill. So for example, if I have my patient and I spend 40 minutes one-on-one with the Medicare patient, then Medicare says 40 minutes is the total time, and that is going to constrain you to 3 time units. So let's take an example. Let's say with a Medicare patient, or with either patient, you spend 10 minutes of Therax, 10 minutes doing therapeutic activity, and 10 minutes of one-on-one time during neuro-read. Medicare says you have 30 minutes of one-on-one time, and you can only bill 2 minutes because of the total time rule. And so you would bill, you get to choose because each one of these is equal, and I would choose to bill the neuro-read and the therapeutic activity. If one of these was like 12 minutes, 10 minutes, and 10 minutes, you would have to bill the one with the most time first. With a commercial payer that pays you incrementally, as we looked at that CPT definition, you do the 10 minutes of each of these 3 activities, then you have to ask yourself 2 questions. Was it one-on-one time? Yes. And does it meet the midpoint rule? So all 3 of these are more than 8. And so for the commercial payer that doesn't reference Medicare or total time, then each one of these is distinct and different. They're different activities. They're different procedures. They meet the midpoint rule. Then we could bill all 3 units to a commercial payer that pays you incrementally. So a second example where Medicare might help you, the total treatment time might help you, is where you have 32 minutes of Therax, 6 minutes of Theract, for example. So you have 38 minutes. Medicare says you did 38 minutes of FaceTime with the patient, then you can bill 3 units to that patient. So you get to borrow time, basically, to get your 3rd unit. So even though your therapeutic activity didn't reach the 8-minute threshold, because you had 38 minutes of one-on-one time with the patient, you could bill 3 units. But that commercial payer that pays you based on incremental time, you have to meet the threshold for each activity. And so you have 32 minutes of Therax, that's only going to allow you to bill 2 units because this one doesn't meet the 8-minute threshold. And so it's really important to understand that you want to plan ahead of time. So when you are treating your patient, you decide before they walk in the door what you're going to need to do today, what procedures you're going to do with the patient, what activities, and I would encourage you to also decide how you're going to bill that before you actually treat the patient, so you don't end up in a scenario like this where you have time that you can't actually bill. So I'll give you just an Illinois example for as an illustrative purpose. So 45-minute slot, Blue Cross of Illinois pays you incrementally, and so the patient spends 23 minutes of the PT doing Theract and 23 minutes of the PT doing neuro-read. Both of those meet that midpoint threshold for 2 units. So I have 4 units that I can bill for that time. And then let's say the patient just spends 10 minutes with the tech. I think your patients probably spend more time than that. They do 10 minutes of one-on-one Therax with the tech, then you have another unit of Therax to bill. And so for that example, you have 56 minutes of time and you have 5 units to bill. If you go to a 40-minute schedule, which I recommend, then you still have 5 units to bill for a commercial payer that pays you incrementally. And so 23 minutes of therapeutic activity is 2 units. 9 minutes of neuro-read would be 1. Let's say the therapist, the PT, spends 8 minutes with the patient discussing their exercise program, updating their home program, giving them new things to do, etc. And then they spend 15 more minutes in Therax with the tech. We would add the 15 and the 8 together if that payer allows techs to treat patients and bill. and again have 5 units out of that period of time. Another example would be 10 minutes of Theract with the therapist, 23 minutes of NeuroRead with the therapist. That gives me 3 units to bill for that time. Then I spend the last 7 minutes, again, maybe updating the home exercise program or showing the patient new exercises that I want them to do. And then they spend another 16 minutes with the tech. Again, that is 5 units to bill. And I think, again, most of the time, your patients are spending more time with the tech than that, but that would be the minimal number of minutes to actually get to that 5th unit. So it's important to get paid for what you do. Charge diversity paints a better picture of medical necessity. So billing Therax, Theract, NeuroRead together shows a better, paints a better picture of the skill the therapist required than just billing Therax, for example. So once you get paid for what you do, we know that payers are tracking data, and we want you to paint that picture of medical necessity. And I want you to get paid for the one-on-one care that you're providing, because you obviously have a nice setup where you're doing one-on-one care with the patient. They're spending a lot of time with you. They're getting high-quality care, and so we want to make sure you get paid for that. These are the most commonly used timed codes for billing therapy. We're not going to cover all of those because you don't bill all of those, but we're going to go through some of the most common ones. So Therax, by definition, all of the one-on-one codes have this in the introduction of the code: one-on-one therapy, one or more areas, and then it goes into the definition of the code. So Therax, to develop strength, endurance, range of motion, and flexibility. So if your goal for what you're doing is to develop strength, endurance, range of motion, and flexibility, you're billing this as Therax. These are your traditional exercises. These are your quad sets. These are your straight leg raise. This is your education on their home exercise program or on exercise principles. Folks typically ask me, how do I bill education that I'm providing to the patient? Well, you bill it based on the purpose of what you're trying to do with the patient. So if my purpose is to educate the patient on the home exercise so that they can work on their strength, endurance, range of motion, then I'm going to bill that as Therax. If my purpose is to educate the patient on balance, for instance, then it's NeuroRead. If my purpose is to educate the patient on things that I want them to do in their office for their posture or their proprioception, that might be NeuroRead. So it's the purpose of what you're trying to accomplish. When you are going to bill Therax, you want to make sure your evaluation data is congruent with billing Therax. So there should be some strength deficits, some range of motion deficits, some endurance deficits, and functional deficits related to those strength, endurance, and range of motion deficits. Make sure that when you document Therax that you list the exercises the patient's doing, the reps, weights if they're doing weights or TheraBand or anything like that, and then the total amount of time spent doing Therax for that treatment session for the day. Why does it require the skill of a therapist? So don't have an exercise, for example, that you have put in the patient's home exercise program, and then you make a statement that the patient's independent with their home exercise program, and then that exercise shows up on the flow sheet for the next treatment day without some qualification that you're correcting their technique or you're upping their reps or you're doing something different with that. So we don't want to be billing for something that we say the patient can do independently. NeuroRead, by definition, is neuromuscular re-education of movement, balance, coordination, kinesthetic sense, posture, and proprioception for the purpose of sitting or standing. So, meaning that if you work on these things, it's going to help the patient be more in line or be able to do sitting activities or standing activities better. So, for example, for body gears, you use functional excursion of tissues with FMP. You do motor control training for smooth coordinated contractions. You work on volitional contractions of muscles. You work on activities to improve posture. You work on proprioceptive training for an ankle sprain patient, for example. You have a patient that has balance deficits where you're working on the balance deficits. You're doing PNF with a patient. All of those would be appropriately billed under neuromuscular re-ed. For the neuromuscular re-ed, again, make sure your evaluation data is congruent. So you address the patient has balance deficits, they have kinesthetic deficits, they have proprioceptive deficits, they have motor control issues, describe those, they have postural issues, describe those, and how do those issues impact their ability to perform functions in sitting or standing. When you document the neuro re-ed activities that you're doing, make sure that you describe what you're doing and why that requires the skill of a therapist, how much total time you're spending on that particular code. So for example, you are doing facilitated bridging for left gluteal activation for gait. That would make a reviewer understand that it falls into this code and the therapist's skill is required. Gait training is not a code that you use very often, but I do want to make sure that you understand when it's appropriate to bill. This is your traditional gait training. So the definition of the code is very simple. Gait training includes stair climbing. These are the types of patients where you've got a lower extremity post-op patient, for example, hip, knee, ankle. You're teaching them how to do non-weight bearing gait with crutches, or the patient has now weight-bearing status has now changed and they've gone from no weight-bearing to partial weight-bearing, and you're giving them those instructions on how to do that correctly. Or you're progressing someone from non-weight-bearing or partial weight-bearing to full weight-bearing, or you're working on their gait pattern for that perspective. So this is your traditional gait training activities. And it includes, straight line walking as well as stairs and obstacles and curbs, etc. So if you're going to build gait training, make sure that you document the gait deficits. What's causing the gait deficits? What assistive device are they using, if any? What's their weight bearing status? How do they do sit to stand? How are they performing on steps, obstacles, etc. And then if you're doing the gait training, again, what are you doing? How much time did you spend in that code? And why does it require the skill of a therapist? Manual therapy is not a code you guys built a whole lot, but I left it in here because I want you to understand the difference between manual therapy and therapeutic activity. So manual therapy, by definition, in the CPT book, is manual techniques that include soft tissue mode, joint mode, manipulation, manual traction, manual lymphatic drainage. So these are things where the patient's pretty much a passive participant. You are mobilizing their patella, for instance. Patient's sitting there, you're mobilizing their patella. And we'll come back to this, but as opposed to therapeutic activity. So therapeutic activity, by definition, is dynamic activities to improve functional performance. And that is all the code says, dynamic activities to improve functional performance, period, the end. Now, I listed 6 words here that are examples of function, but this is not an exhaustive list. There's probably thousands of words that describe function, including breathing and other, inging words. But anyway, so the key point of therapeutic activity is dynamic and functional. And so when you guys treat your patients, you use the cascade of techniques principle. I want you to make sure that you're demonstrating the dynamic activity part in conjunction with any of the soft tissue work that you're doing. And make sure that you tag the function to the documentation. So if I am, working on diaphragmatic, excursion for breathing, I'm working on shoulder mobilization for reaching, etc. So make sure that it speaks to what is dynamic about it and what's functional about it when you're going to build this code. And so make sure that in your evaluation data you have the functional deficits that you're addressing. For example, the patient can't reach into a cabinet above 90 degrees of shoulder flexion. They have severe right shoulder pain when they brush their hair. Patient has severe pain with sit to stand. Whatever it is that the patient's struggling with from a functional perspective. And your outcome data is going to speak to that very easily. Look at those that information to get a list of things that the patient is struggling with. So what's the patient doing actively when you're billing this code? And then what makes the activity dynamic? I do recommend removing the words manual therapy from the documentation if you're billing therapeutic activity, because reviewers are not therapists and they don't know the difference between functional manual therapy and manual therapy. So when you use the words manual therapy, they're going to think immediately that it should be included in the manual therapy code. So as I understand what you guys do and watch you treat patients, you're doing dynamic activities to improve functional performance, and make sure that your documentation supports that. This is not a code that I see you use a whole lot, but I want to make sure you understand it's here and available to you, especially for some of your clinics that have more Medicare patients, or you're treating Medicare patients with balance deficits. So the code, by definition, is use of a standardized performance test to measure physical performance or function. And so by definition of this code, this is a standardized test that is valid and reliable, you can look up in the literature, has some predictive value, has a written report and a score, and the score means something. So for the most common things I see this used for is Berg, timed up and go, dynamic gait, functional capacity eval, if you're having workers' comp patients you're doing those with, or 6-minute walk test, those kinds of standardized performance tests. You cannot bill this code on the same day as an eval or re-eval. So, for example, let's say I have a Medicare patient. I have performed a 30-second single leg stance screen. The patient struggles with that. I know the patient has a fall in their history over the last year. So in my plan, after I do my eval, my plan is next visit, do a full battery of balance assessment tests. And so then on my next visit, I do the Berg and the timed up and go and maybe a 6-minute walk test. And I put all that in my documentation. This is a 15-minute unit code, and I could bill for all the time that it took me to do those 3 tests. And then let's say 3 weeks later, I want to reevaluate where we are with the patient's balance. I can redo those tests and rebill this code. But again, you just cannot bill it on the same day that you bill an eval or re-eval. Dry needling is something that a lot of therapists are doing these days. Again, I've been spending a good amount of time reviewing your contracts, reviewing your payer policies for the payers that Body Gear is contracted with. And what I have found is, I have not found an insurance payer that states that they pay for dry needling. And in fact, most of them explicitly state that they don't pay for dry needling, and they consider it experimental or investigational. So when a payer says we don't cover this, then we are obligated to inform the patient it's not paid by their payer and make sure that they understand that when we do provide this service, it would be a cash-based service. Because your payers say, it's experimental, investigational, non-covered, you can't just fold it into other codes, because that would be considered coding around a payer policy. The APTA and the members of the CPT committee have stated that dry needling does not have a code. Was not included initially in the manual or NeuroRead code description. And so when a procedure does not have a code, the direction from the CPT book is to bill it as an unlisted code, which would be 97799. And so again, that's a cash-based service. The time that you spend identifying issues and trigger points and pain issues and all of those traditional physical therapy things that you're doing, that is billable time. The time that you spend sticking the needles in the patient, specifically doing dry needling, would be billed as this 97799. All right, just a few words about the 2018 Medicare fee schedule. In the last couple of years, the therapy codes were revalued. They were reevaluated and revalued. And so there are some codes in 2018 for Medicare specifically that are going to increase in value. And so that's neuroread and therapeutic activity specifically for you. And the rest of this list is also going up across the country. Bad news is TheraX, aquatic therapy, manual therapy, and self-care home management are going down this year. So what does that look like for you? These values are specifically for Chicago, but they're not far off for Missouri and California and other areas of Illinois. But basically, you're getting a slight bump for Naval. You're getting a 2.9% increase for NeuroRead, 8.4% for gait training, 17.1% for therapeutic activity. And so that's a big jump for the therapeutic activity code. What is going down? TheraX by 5.5% and manual therapy by 7.1%. So just good information to know and understand for 2018 for Medicare. For the 2018 Medicare therapy cap, you've probably heard that on February the 9th, as part of the Budget Act, the therapy cap was removed, but we still have a threshold. And so we don't have a hard therapy cap anymore. But basically, Congress passed the law that said you still, as a therapist, need to put the KX on the claim at the threshold that's been defined. So for this year, that's $2,010 for PT and speech combined, and OT has a separate threshold of $2,010. Because we want to make sure that you're continuing to provide services that are medically necessary. So basically, you're going to do what you've been doing for years. Put the KX on the claim if you're going to continue to treat the patient past the 2010 mark, and you should if they continue to have medical necessity. Put the KX on the claim, file the claim, and make sure you're documenting that the patient continues to have medical necessity. So our recommendations for you are to look at your charge diversity, make sure that you're billing for the goal of the activities being performed, understand the difference between the CPT rule and the Medicare rule, and use the correct rule according to the payer policies that you have. So if it's Medicare or federal payer, you're following the Medicare rule. If it's commercial insurance, unless they tell you differently that they follow Medicare, it's the CPT rule. We want to make sure you charge for all the time spent with your patients. You guys have the beauty and it's very nice that you're able to see your patients one-on-one, that they spend, a good chunk of the time with the therapist and they work with the tech. So I want to make sure that you're charging for all the time that you spend with the patient and get credit for the value that you're providing so that Body Gears can thrive financially and continue to allow their therapists to work in an environment that really strives quality care and one-on-one care. I do recommend that you switch from 45 to 40 minutes because it's going to give you more time slots in your schedule and eliminate some of the impact that a cancellation or a no-show is going to have on your budget. And because it's just a minor switch, it's 5 minutes, it's not 15 or 20, it's going to have less impact on you as a therapist. The patients are probably not going to even feel the difference, and but allows you to get more patients in on the day and prevents the no-show and cancel from really destroying your numbers at the end of the day. Check your interactions. Are you unknowingly giving patients permission to skip therapy? So if you say, Ms. Smith, I need you to come in twice a week, it's going to take about 6 weeks for us to get to your goals, and the patient says, well, I'm not sure I can come in every twice a week and I have all these commitments. To have a really good conversation with the patient about the value of therapy and what's needed in order to accomplish their goals versus saying, oh, well, don't worry about it, just call us if you need to cancel, because then you've given the impression, well, therapy's not the priority, and you don't want to give your patients that impression. Make sure you get all your notes checked in on time. If the notes aren't checked in, the claims can't be filed. Make sure that you document at the point of service so that you don't get behind on documentation. We've already talked about dry needling. Be compliant. We want you to follow the rules. We don't want you to underbill. We don't want you to overbill. Follow the rules, charge for the time, understand how coding and billing works, ask questions if you have them, and we're going to know the rules for the payers instead of applying the strictest rule across the board. You guys do a great job with your patients. I watched your patient interactions. You're doing a great job getting good outcomes. Continue to do that. Continue to impress the patients and get great results. And remember to document the function when you're billing the neurorehab and therapeutic activity. So if you have questions, we're going to spend some time answering those. I welcome those questions, and I'm glad to try to help you make sense of all this information. Billing and coding is difficult sometimes to wrap your head around. So I'm here to answer those questions. We'll be doing some further sessions to get those questions answered for you. Thank you for spending the time listening to this, and I hope you have a great day.